Good evening, everyone. Welcome to the Alaska Eating Disorders Fall 2023 Project ECHO. My name is Beth Rose. My pronouns are she, her, and I'm one of the co-founders of the Alaska Eating Disorders Alliance. Tonight's ECHO session offers a forum for Alaska interdisciplinary healthcare providers to connect with eating disorder experts and with each other. This is the second of 4 sessions being held this fall, and we hope you will join us for the remaining 2. Each session includes a didactic presentation on a key eating disorder topic from a subject matter expert, a time for Q&A, and a case presentation from a local provider with the opportunity for you to engage and learn from other professionals in the field. This series has been guided by a hub team of professionals and experts in eating disorders, and you will find their names with a little hub team after the name so you can identify them. And I might ask everyone on the hub team to introduce yourselves again in the chat, because people who are joining now won't have seen your introductions, so you can just put your names in there. And our series has been approved for continuing education units. Participants can claim 1.5 credit hours per session of this ECHO series. In order to claim credits, you must attend the live session for at least 90% of the full session time and complete an evaluation form, after which you'll be redirected to receive and download confirmation of your continuing education credits. At the end of our session today, a link to that evaluation will be provided in the chat box. And I encourage all participants to fill out the survey, as it tells us how we're doing and how we can improve. And so before we jump in with tonight's presentation, here's a few Zoom reminders. Closed captions are automatically generated and available by pressing the CC button at the bottom of your Zoom screen. Please take a moment to turn on your camera so that we can all get to know each other. And the camera icon is on the lower left of your screen. Please keep your mic muted during the presentations, and when you're not speaking, you can mute and unmute yourself by clicking on the microphone icon on the lower left of the screen. Participating and engaging with a group is integral to the All Teach, All Learn philosophy that underpins the ECHO program. We encourage everyone to ask questions and make comments during the session by using the chat box, or when appropriate, unmuting yourself and sharing directly with the group during the Q&A session. And you're also welcome to private chat the session host, me, or any member of the hub team if you'd like your questions shared anonymously. As you see, people are introducing yourself in the chat box. Please, if you haven't done so, share your name, role, organization, where you're joining us from. And if you'd like to add what you hope to get out of this ECHO, that would be great as well. Please note that the opinions of the hub team and the presenters are their own and do not necessarily represent those of Akita or any ECHO sponsor. Additionally, Project ECHO is not HIPAA compliant. Therefore, no protected health information is to be shared or displayed at any time. And thank you to everyone for following these guidelines. And finally, I'd like to take a brief moment to pause for a land acknowledgement. And although this is a virtual space, our ECHO team is joining you from Anchorage, and as such, we want to thank the Dena'ina people for their stewardship of the lands, water, air, and all life that sustains us within their traditional lands of the Takatnu Cook Inlet region. We respect the Dena'ina cultural ways and their homelands, and shall strive to be good neighbors. Now I'd like to turn the session over to Akita's Executive Director, Becca Kirian, to share a bit about the vision that's driving this initiative, the purpose of our ECHO, what's on today's agenda, and offer some reminders about best practices and language when engaging in today's discussion.
Thanks, Beth. I'm Becca Kirian, the Executive Director of the Alaska Eating Disorders Alliance, and I'm thrilled to welcome you all this evening. The goal of this Project ECHO is to work together to grow capacity within our local healthcare system to better understand, diagnose, and treat eating disorders in Alaska. During our time together, we'll be learning through the presentations and discussions, and we want to be mindful of creating a welcoming learning community. Words matter, and they are powerful. This is an open space where all voices and bodies are welcome. We encourage you to seek ways to use inclusive, non-stigmatizing language. Let me start with a broad outline of this evening's agenda. We will begin by a presentation by Dr. Melissa O'Neill and Dr. Yolanda Evans titled Practical Considerations for Choosing the Right Level of Care. Dr. Melissa O'Neill is a licensed professional counselor in Anchorage and holds her certified eating disorder specialist supervisor credential. She currently practices with Counseling Anchorage, an interdisciplinary outpatient clinic in Alaska, devoted to working with individuals and families experiencing eating disorders and related issues. Dr. O'Neill is the PhD program coordinator and a clinical assistant professor with Adams State University School of Counselor Education. She has worked in the field of eating disorders for over 10 years in various capacities, including assessment and admissions for a treatment center, clinical management, intensive outpatient, and marketing and outreach. Dr. Yolanda Evans is an associate professor in the Department of Pediatrics at the University of Washington. She was born and raised in Anchorage, Alaska, and completed undergraduate studies receiving a Bachelor of Science in Biology at the University of Alaska, Anchorage, and medical doctorate from Oregon Health Sciences University. After completing residency in pediatrics at the University of Washington, she went on to complete a fellowship in adolescent medicine and an MPH at UW. Dr. Evans has served a number of roles since joining the faculty in the University of Washington Department of Pediatrics, including Director of Telemedicine at Seattle Children's Hospital, Medical Director of the Adolescent Wellness Clinic for Management of Youth with Medical Complications of Obesity, Division of Adolescent Medicine Clinical Director, and most currently Medical Director for the Adolescent Outpatient Eating Disorders Clinic, and the head of the Division of Adolescent Medicine. In 2012, she started a telehealth consultation clinic with Alaska Native Tribal Health Consortium and continues to offer clinical care for youth around issues related to reproductive health, contraception, eating disorders, and gender care. Her research includes using technologies and social media to improve access to safe, reliable healthcare for adolescents. In her free time, she enjoys dancing and traveling with her husband and 3 children. After the presentation, Dr. O'Neill and Dr. Evans will lead our Q&A with our participants. Our session will conclude with a case presentation by Lisa Alexia. Without further ado, I'll pass the session over to Dr. O'Neill and Dr. Evans to share our didactic presentation.
Thank you so much, Becca and Beth. Let me just share the slides really briefly. Get everything going. All right. So hopefully everyone can see the slides. Good. All right. So thank you so much for the intros. I'm really honored to be presenting with Dr. O'Neill today on practical considerations for choosing the right level of care. And it's really been a fun process because we have different perspectives. Me coming from the medical side and Dr. O'Neill from the behavioral health side. So I hope that this presentation gives everybody a little bit more scope and perspective. And so we have land acknowledgement as well, being that we're in different areas. So just acknowledging that there are 574 federally recognized tribes in the US and approximately 400 that are not federally recognized, including the Duwamish tribe, on whose land the University of Washington and Seattle Children's reside. This is unceded Indigenous land, the traditional territories of the Salish peoples. And the land in eastern Louisville, on which one presenter, Dr. O'Neill, resides, is the land of the Salagweti Osagi and the Shawandasi Tula, Hopewell culture, and Adena culture. And we've got some links there if you'd like to learn more about the land on whose land you reside. And then we want to pause as well to acknowledge labor upon which our country, state, and institutions have been built. And remember that our country has been built on the labor of enslaved people who were kidnapped and brought from the continent of Africa, and recognize the ongoing contribution of their survivors. We also acknowledge immigrant labor, including voluntary, involuntary, trafficked, forced, and undocumented peoples who contribute to the building of our country and continue to serve within our labor force, and acknowledge all unpaid caregiving labor as well. And finally, I'm coming from an academic institution and want to acknowledge that the institution relies on hourly student work contingent, both paid and unpaid, and want to recognize those contributions too. Yeah, I'll turn it over to Dr. O'Neill.
Okay, we're going to then kick it off with our learning objectives for this evening. So hopefully what you can expect for yourself as a learner is that you'll be able to apply best practices to the initial encounter when working with an individual experiencing an eating disorder. You'll be able to identify indicators for an individual needing to seek a higher level of care for their eating disorder and identify the systems and resources available to Alaskans specifically needing treatment for their eating disorder. All right. So I couldn't hesitate to include a photo of our beloved moose, and in considering approaching the encounter, so approaching the initial meeting with our patient or our client. And so sometimes that can elicit some feelings from us as providers. So things that we need to consider are, so I'll speak from my perspective as a mental health provider and then turn it over to Dr. Evans to speak from a medical provider's perspective. So we want to consider if this is if this is the individual's first time seeking treatment or care for their eating disorder or disordered eating behaviors, or if they're experienced. So if they've received care in the past, we want to get a good gauge of what that's looked like for them, as well as the duration of the illness. Has this started in early childhood? Is this something that has just manifested in the last couple of months? And getting a good read on what the behaviors have looked like over the course of the illness. Are they returning from a higher level of care? So if you see the acronym HLOC throughout our presentation, that indicates higher level of care. So anything above the outpatient level of care. Are they returning from perhaps a stay in inpatient, residential, partial hospitalization, or intensive outpatient and coming back into your practice in outpatient? Do they have social supports, and what is their involvement? So are these people you might include in perhaps family therapy or couples therapy? Are there caregivers involved? And what the structure looks like, as well as what the dynamics look like, and what we need to pay attention to in terms of their involvement, our communication with them, and essentially the structure. Like, do we need to consider family-based therapy, emotion-focused family therapy? Do we need to consider more of an individually focused care for the individual? And then I can't emphasize this enough, the interdisciplinary team involvement. So who is on their care team? And in the outpatient world, we often see, and we're going to talk about this in a little bit, but we often see mental health providers, a registered dietitian, nutritionist, medical providers, et cetera. And so getting a good glimpse of who is and isn't on their team and who we may need to involve. And then I just wanted to indicate that oftentimes my language is I will use the term clients, because in outpatient, I typically use the word clients when referring to individuals, whereas Dr. Evans may use the term patients, which is more akin to the higher levels of care, the inpatient or medical world. I'll hand it over to you.
Yeah, I don't have a lot to add, but just to acknowledge to, as I'm a pediatrician by training as well. And so when I'm thinking and framing my thoughts around people experiencing eating disorders, it's often with that lens of someone who's caring for minors or young adults. So I'll use the term patients, and you might hear me speaking about a youth or saying a youth, but that doesn't mean I'm only focused, or that our content is solely for youth. So just putting that out there as well. It's just my lens is as a pediatrician and adolescent specialist. And I think the other thing I would add to these things to consider when you're first meeting someone is getting a gauge on motivation and insight too. So as you're working with them, talking with them, understanding a little bit more about the impact of their experience on their life and how engaged they are, or what insights they have into wanting to work towards recovery, because that'll definitely help kind of guide, the journey of where you recommend they receive care. Right, and then just to add a little bit more here, I think again, I can't emphasize enough the importance of having a team and being a team. And I also recognize that that's not always feasible, depending on where people are and their access to resources. But we put some of the major roles on here, and each of us has kind of the things that we have to offer. Some of the roles that aren't included on here: speech therapy, occupational therapy. There are other nursing support, social work support, health aides, and behavioral health caseworkers. And so there are many people who might be involved in teams. Sometimes it's people at school, coaches. So we have these here kind of listing out who typically does what, but also want to acknowledge that sometimes we have to step in and serve multiple roles. No matter what, even if we're working with family members or other support people who are serving roles on the team, the care coordination and communication is really key in helping people with next steps and working towards recovery. So we often in our clinic will set up regular care conferences where we involve caregivers and all of the different team members within the community to just touch base and talk through where are we, where do we want to go, what are our next steps, and make sure we're all aligned in the recommendations that we're giving. So I'm going to keep us going. Most people might know this or might not, but wanted to definitely offer that there are guidelines and recommendations for how to care for people experiencing eating disorders. And so all of these actually recommend screening, completing an assessment, and the American Academy of Child and Adolescent Psychiatry recommends mental health providers screening and youth and teens for eating disorders. The APA, or American Psychiatric Association, has really wonderful guidelines and even a pocket guide that people can download related to screenings and levels of care. And then the Society for Adolescent Health and Medicine really recommends, again, emphasis on mental health, but as a historically physician society really works on weight restoration if that's an issue, and making sure we're managing any physiologic complications of malnutrition if that's based on a restrictive eating disorder. So all of them really are aligned in recommending screening, assessment, and then working towards weight restoration and mental health involvement. I don't know, Dr. O'Neill, if you have any other things to add.
I would just add that it's really common for mental health providers to follow the American Psychiatric Association guidelines and recommendations. And this can be really handy. They actually just came out with a 2023 version of their guidelines that we referenced throughout this presentation. And it can be really handy, especially when you're considering level of care needs. All right. So I wanted to provide an overview of essentially what mental health providers are looking at and looking for in terms of kind of within our scope of care. So we're reviewing the symptoms, including this could be anything from like weight fluctuations. The individual endorses a preoccupation with food or body image distress. They might be engaged in social isolation, mood swings. They also could be experiencing other, there's a multitude of symptoms that they might be experiencing. Sleep issues is a really common thing that we see. Also, preoccupation with like calorie counting or food rules and rituals. And so as you're reviewing the symptoms, this is there's again a pretty comprehensive guide in the APA guidelines, but this just gives you kind of an idea of some of the main things that we're looking for when we're gathering information. We're also looking at behavioral indicators. So you're looking at changes in eating behaviors, patterns. Have they increased the amount of exercise that they're engaged in, or the type of exercise? Also, you're looking at exercise also is considered often a compensatory behavior. So other possible compensatory behaviors including purging or use of substances as a compensatory behavior. In addition to if they're engaged in using other substances or may have a substance use disorder. Are they drinking excess water, excess caffeine? And so really looking at what's the shift in behavior, and then also what's the emotional regulation, essentially, and emotional state connected to those behaviors, as well as what's going on in their environment. Starting to learn what impact it's having on their relationships within their family system, within other relationships. Maybe it's impacting their work environment. And if there are significant impacts happening, then that's where we're starting to see that there could certainly be an issue, and a very serious issue. We're also looking at co-occurring conditions. So I've listed a few of the most common co-occurring mental health conditions, including depression. I included the acronym for major depressive disorder, but depression, anxiety, OCD is a common co-occurring issue, as well as something that often there's a misdiagnosis. So we might actually see a presentation of OCD that looks like an eating disorder. So starting to identify those distinctions. A common co-occurrence with the experience of trauma and reactions and the experience of re-traumatization, suicidal ideation, non-suicidal self-injury, substance use disorder, etc. So those we conceptualize eating disorders as more than the behavior, and more than the thoughts or the emotional experience. And oftentimes we see these co-occurring conditions from the mental health perspective. We are also looking at, and Dr. Evans talked about this a little bit, their motivation for recovery. Are they absolutely, feet glued to the ground? I am not going to budge. I am perfectly comfortable in my eating disorder. I'm perfectly okay. This is, these behaviors serve a purpose. And so no desire for recovery, or maybe there is a desire or really, really wanting some help and support in recovery. Again, looking at those social supports, and this is one thing that I'll continue to emphasize so much, is who are their social supports and how can they get support, but then how can that all work within the system to help the individual. And then we also want to look at what resources they have available. So do they have insurance? Does their insurance provide access to care? Where are they? If we're looking at Alaska, where are they in Alaska? Are they in a rural location? Are they in Anchorage, where there is access to medical care and the majority of our providers? So all of these kind of go into the mental health considerations.
And then on the medical side, I think, thinking about the people that we take care of, if they're coming in for a regular visit, a well visit, annual physical, making sure we're taking a look at their growth curve, taking a look at trends, and really paying attention to those changes and fluctuations in weight or vital signs that might be an indicator that we should dig a little deeper and ask some questions and screen. And if in a medical visit, there is a concern that somebody might be changing their body shape or size in a way that's dangerous, potentially, share that concern and make sure we schedule follow-up for monitoring. I think that's something that I see, amongst my pediatric colleagues quite a bit is there's been an emphasis on, okay, we need you to exercise, eat consistently, a balanced diet, all these different things. And it's usually pretty obvious when a child falls off their growth curve or goes up on their growth curve. And in my mind, that's something that I want to ask about a bit more in a way that's non-judgmental and just says, hey, I noticed something that I'm a little worried about. In the medical visits, we usually obtain what we call a blind weight. So when people are coming in, I'm not sharing data with them. As adults, I don't know how many of you have gone to the doctor's office recently, but they say, okay, get on the scale. You're right there looking at the number. They take your blood pressure, your heart rate. You're right there looking at all that data. And so we don't show any of that. We usually have everybody come in exactly the same way. They go to the restroom and void. We have them change into a gown. Our scales are all like, they have numberless actually, and just automatically load into our system. But if you're at a place where they're not, have them stand on the scale backwards so that they're not looking at the screen. And for me, inevitably, they'll be like, what's my weight? I want to know what it is. And so I usually say, we'll get to that. Let's have you change back into your, change back. We're going to talk. I'm going to do the physical exam. And I kind of like bide my time a little bit with that question in order to really ask a little bit more about why they want to know. And then in the medical visits, again, similar with the mental health, but really avoiding language that gives food any character traits. I'm not talking about food as good or bad. All food fits is kind of the model we have. Food has purpose and we need the energy to fuel our body. And often in the medical visits too, I'm kind of modeling that behavior for the caregivers in the room who are talking about junk food, good food, bad food, or the individual. And then really from the medical perspective, I'm usually emphasizing the importance of establishing a care team that includes mental health. Because people often will come into the visits with me saying, okay, I just want you to check my blood pressure and make sure I'm okay. And then they don't necessarily feel ready or want to put in the effort and time to really work on the issue at hand yet. So a lot of what I'm doing is helping with motivation and guiding them to really engage in a team. And with that team too, I'm also then getting that release of information and talking with the care team members and gaining more understanding of their level of expertise in caring for people experiencing eating disorders. And often we're working with each other, and there's a lot of learning that happens if it's somebody who doesn't have that expertise. So again, the importance of communication is really key. And we'll talk a bit more for the medical visit about like which parts of the physical exam might prompt you to recommend higher than outpatient level of care. So I've already kind of said this, but in general, screen everyone for disordered eating. Really, I think we all have our own biases and assumptions, and really those need to go. And don't make any assumptions based on the race, ethnicity, language, size, gender identity, economic background of the person in front of you. And really, like, again, reviewing the data that you have with growth curves and vital signs. And for me, I usually spend a couple minutes talking with the teen alone, having the caregiver step out for a bit. And when I'm doing that, I'm usually asking if they have tried anything to change their body shape or size, what they've tried, do they have a goal weight, or do they have fear foods or foods they're avoiding? Have they downloaded any apps to look at calories or things like that? Have they used any of those compensatory behaviors like exercise, purging, appetite suppressants, water loading, those kind of things? And based on what they tell me, we will work through, okay, does this meet the criteria for a diagnosis based on DSM? And then if they've already had an established eating disorder, are these behaviors escalating and we need to proceed to a higher level of care? So for the medical visit, we're asking a lot of information. It's a lot to fit into, 15 minutes, but so important.
All right. So, and then in terms of general approaches to mental health care visits, very similar to what Dr. Evans was talking about, it is our responsibility to regard our clients with curiosity and with an open and non-judgmental attitude, which involves checking our beliefs, biases, and our privileges in the room. And one thing that really stands out about this in particular, in addition to learning and understanding, acknowledging our clients' cultural background, as well as our own, is also when there are caregivers involved, or truly the individual themselves as well, is that blame and shame do not belong in this space. And so it's unfortunately it was old practice in working with individuals experiencing eating disorders that, this is an old idea that parents are to blame, and this must be a result of the parenting style or whatever. And there's no substantiated evidence to that, and in fact quite the opposite. So this is something that actually our team at Counseling Anchorage was talking about today, just in terms of also the these emotions, these very deeply rooted emotions of self-blame and shame, are incredibly difficult for caregivers to work through. And so again, it's our responsibility as providers to support the caregivers in that process as well. Because if we're not acknowledging that, and if we're not helping to support them, that can inadvertently perpetuate some of the issue. In addition, we want to gather a subjective narrative from the client and their loved ones, so maybe their caregivers, whomever's involved when possible. So this includes food recall, so maybe like a 24-hour recall, as well as like what are their current norms, as well as any changes recently and over the course of the duration of their illness. Also getting a full list and asking about behaviors, not only the behaviors that you may suspect, asking about all of them, because there could be something going on that again, your bias has kind of got your blinders on. So asking about thoughts and associated feelings and a history of trauma, as well as their mental health history. Also, I did just want to mention, consider some assessments to administer and some screening tools. And these can be helpful, in particular when you're not entirely sure and you're trying to distinguish maybe between between diagnostic criteria. However, the validity and reliability of some of these assessments and screening tools, especially cross-culturally, are not that great. So again, going back to that subjective narrative is going to be your key. So you're determining treatment history, severity of presentation, as well as, again, if the outpatient team exists. And then you're going to start to begin the percolation process of treatment planning and providing recommendations. In this considers, and as you're creating these goals, you're considering at what level of care, based on symptom presentation, behavioral indicators, associated thoughts, feelings, and their current mental health status, what level of care they may be needing. So in addition, these higher level of care indicators, it can be really tricky then, especially at the outpatient level, when you have to be the person to say, I think you need a higher level of care. So one of the questions that comes up frequently is, at what point do we have the conversation, and how do we set those boundaries for making that recommendation, in particular when someone's motivation for recovery is low, meaning they don't even want to be there in the office with you. They want to be far away from talking about what's going on in terms of their disordered eating disorder. So you might have to work. I strongly encourage, if there's a treatment team present, consulting and collaborating with them to identify what boundaries need to be set in terms of, this is something that's a higher level of care is absolutely needed and indicated. We've reached, severity in terms of behaviors, perhaps the individual is medically compromised, and we need to be seeking higher level of care. How to frame those conversations, and oftentimes the mental health provider is the person to start the process in having those conversations because of the emotional connection that we have. And so, but often, we might bounce that conversation to the medical provider. So it kind of depends on the treatment team. There's also there's quite a few myths and assumptions out there that somebody seeking and working in a higher level of care will solve all of the concerns, and they're going to go seek treatment and then come back to outpatient recovered or in recovery. And unfortunately, we know that that's not necessarily the case. There's a lot of work left to be done. And so we really want to be kind of on our A game when we're completing that initial intake back into our care and really sustaining quality care, and not jumping into too much too quickly with our clients as well. As well as we need to consider what insurance is covering and knowing what our options are in Alaska. So knowing what our medical options are, knowing where do we need to access the emergency department. Is that kind of our best next step in terms of providing medical stability to somebody who's kind of on the verge of needing that? Dr. Evans, is there anything you would add here?
I think for the insurance coverage piece too, just we'll have a little bit more about the levels of care themselves in a second, but sometimes people discharge from higher level of care because insurance is not covering things anymore, not necessarily because they're clinically ready to step down. So I think just acknowledging that too, again, to Dr. Rendell's point, really when they come back, checking in with them around what thoughts are still there, what behaviors are still there, were they started on medications when they were in the higher level of care and now they need follow-up for those. Did they leave early? Was it recommended that they go from partial hospitalization to intensive outpatient, but they decided to come on home to gauge just like how much follow-up you're going to need to set in place with them. And then being really clear around, okay, when is this beyond my capacity? When are we to the point where, okay, yep, nope, we've got to step back up. And that might be based on weight and vital signs, or it might be based on engagement in the behaviors, like how impactful the behaviors are on their day-to-day living. So kind of not that you have to have all those conversations on that first visit back from higher level of care, but definitely conversations to have. I think next we have a poll to help people like solidify some of this information. So we'll give everyone a minute to read. Well, I'll read this case and then we can choose an option. So we have a patient who leaves partial hospitalization, which is a day program. Usually it's Monday through Friday, kind of like a work day. And they skip their intensive outpatient despite recommendations to step down to intensive outpatient. And they're coming to you for a follow-up. So what are your next steps? And this could be you as a mental health provider, as the medical provider. They're coming to you as a dietitian. So let's see. We have a few options here that I'll let you all read through and choose the one that you feel might fit best. All right, let's see our results. I don't have control over the polls. So.
All right. So In terms of the options that we provided, oftentimes some of these are based in things that we have seen, and also some assumptions that could be out there about higher levels of care and an individual, especially with an individual leaving against medical advice. So we have the majority of folks who have answered, you complete an assessment of continued disease process and level of stability and determine appropriate recommendation for level of care. So this is probably considered best practice in terms of how to proceed next. We don't want to assume that, the program that they were at has gotten everything set up for them. We don't want to necessarily assume that insurance is just going to say, yep, good to go. Let's just go ahead and start. No big deal. So, and also it may not necessarily be the case that they are medically or clinically stable enough to continue in the outpatient level of care. And I see the message just is really tough. This is a very tough juncture to reach at the outpatient level. So just want to honor that.
And I think, we've kind of talked about this already and going to move us forward because I realize time is flying. But yeah, I think a lot of times too, there's kind of this assumption that, the family or the team is going to kind of have a plan coming out, and that's not always the case. And so often, we have to step in and help and provide resources for family members or for the individual to keep going with treatment, or to maybe assemble a new team now that they're back from level of care. And I think it's really important from a medical standpoint to assess medical stability too, because especially as somebody's coming out of a higher level of care, having those regular check-ins with them to follow trends as they're getting back into their usual day-to-day life, because higher level of care is very structured and very different than day-to-day. Keep us going. I'm going to go really quickly through, just a call out that restrictive eating disorders and others are really, the malnutrition affects every organ system. And on the medical side, really making sure that, especially if it's a child, we're looking at growth curves, looking at signs of potential pubertal delay, risk factors for osteoporosis, and there have been studies that show brain changes on MRI. And I think just a call out to one of those myths out there is, if somebody has a restrictive eating disorder and they have a uterus and they're not menstruating anymore, well, can't we just supplement? No, we can't actually. There's no evidence that repleting hormones actually helps with bone mineral density. And the sad thing is, even if people do restore, they still are at a loss in terms of that accrual of bone mineral density. So we do want to intervene as quickly as possible with restoration. And I'll turn to you, Dr. Raniel.
Okay. And I'll probably move through this quickly because I know I've touched on some of these points, but in terms of the information to gather when you're determining a level of care that the client may need, is getting that height and weight history. I know these can be challenging questions to ask, and sometimes the caregivers know this. This might be information that you are able to get from the medical provider, like Dr. Evans is talking about. If you're working with a child or an adolescent, you might have the growth curves or their growth charts, which is highly recommended in terms of reviewing for level of care. Also, what their eating patterns are, and I think I've covered quite a few of these already, but just really getting a sense of what the behavioral status is, what their emotional and mental health status is, as well as we also want to know if there's a family history of eating disorders or mental health issues, as well as like what the language is around the home, so to speak, or within the family system of how do they talk about food? What are the values around food? food. And something that Dr. Evans had talked about previously was like this good, bad dichotomy of food. And so how ingrained are those rules about food for this individual and within their system? So in terms of finding the right level of care, I wanted to include all of these. My cat's going to join us. Of course she is. I wanted to include all of the considerations for determining the appropriate level of care that the American Psychiatric Association has presented. So as we've discussed, we're talking about medical and behavioral factors, and also what we need to look at in terms of perhaps they do need inpatient for psychiatric treatment, in terms of there's maybe significant risk of suicide, or whatever those behavioral factors are. Maybe there is maybe there are some safety concerns. So, and again, one thing that I really do want to point out is what their level of motivation to recover is, what their insight into what their eating disorder, disordered eating patterns and behaviors are, like what the impact that is having on in their life. And if there's very low insight, that's likely an indicator for needing a higher level of care, and their willingness to engage in behavioral change. So if you've created the structure for progress to be made in behavioral change, and you're just really not seeing any progress in outpatient for a couple of months, and I want to say a couple of months just as a kind of like soft bookend that, because it's different for everyone, that then we need to start having those conversations of working towards a higher level of care if we're not seeing that progress, as well as what the psychosocial context is, what their environment really is like, if there are a significant amount of stressors, and how we can support the system. In addition, we've talked frequently about higher level of care and what these levels of care are. And this is an excellent depiction of what is included in each level of care in terms of the services provided. So many of us who are working in Alaska are working at that outpatient level of care. I know we've got some folks who are working in the inpatient environment as well. But we don't have those mid-levels of care, intensive outpatient, partial hospitalization, and residential. And you can kind of see, I know it's a little fuzzy, but you can kind of see some of those indicators for what is involved in each of those levels of care. So another thing we have to consider is having the conversation of going out of state. Do we need to go to Washington State, California? There's and consider a treatment center environment. So in terms of symptomology, medical stability, the higher the level of care, the higher amount of services that they're receiving, and then in terms of best practice, they're going to titrate from the highest level of care that they have sought. Hopefully, in an ideal world, when insurance is continuing to, or whatever financial resource that they have available is going to continue to provide, that they bump down to the next lower level of care, back to outpatient.
I think we're running low on time, but just a quick note for the physical exam, and I'm going to focus on that highest level, the medical stability. If you have somebody who is severely bradycardic, or has a low heart rate, or they're fainting, syncopal, they have big shifts in their blood pressure from lying to standing, they have electrolyte abnormalities or EKG abnormalities, those would all be signs and symptoms of needing to proceed to a hospital stay. And so just a note to do a really thorough physical exam. And I always counsel the families and patients, if I'm recommending medical stay, that a medical admission is not mental health therapy. It is really to restore their body to a place where they are hemodynamically stable. And then we're going to refuel their brain a bit. And then we get them to a place where they can get the support and skills to learn the behaviors that'll help them in recovery. And I just want to acknowledge a study by Ansel Keys from World War II, actually, the Minnesota starvation study that showed just the presence of starvation leads to more and more thoughts of wanting to restrict. And so we really, really, really need to refuel the body. And that's what a medical admission does. It offers the 24/7 monitoring as we're refeeding. And monitoring for symptoms of like refeeding syndrome, for example. You can refeed too fast and have shifts in electrolytes. And so I just have here really briefly our admission criteria. They all vary in terms of different hospitals, but in general, they include bradycardia, usually a heart rate 50 to 40. All hospitals are a little bit different. And even there's no athletic heart with that. If somebody's heart rate is 40, that is too low. If they have EKG abnormalities, usually we're seeing prolonged QTC. If they have electrolyte abnormalities, often you'll see low potassium, low sodium, especially if they're water loading. And we're watching for drops in phosphorus and magnesium as they start to restore their nutrition, and often will supplement. And that risk of refeeding is highest in the first 2 weeks of refeeding.
And I just want to jump in really quick. We are running really close on our time. If we can maybe wrap up here just a minute or two, that way we have time for questions. There's some really good questions in our chat box here.
Yeah, so we'll do our last poll here, or and then we can. I don't know if I can submit or not.
So I'll read this out loud for everyone. Your client was seen in the emergency department last night. They received fluids, had labs taken, had an EKG completed, and they were sent home. You have recommended a higher level of care several times already, and they have declined. What do you do next?
Let's see the results.
All right, so this is essentially posing quite the ethical dilemma, and oftentimes we're having to really figure out what is the next best step for the client. And so we've got 56% of folks had said the family or individual, and that's asterisk because when it's a child or adolescent, typically you are going to work with the caregivers or the family. Or an adult typically work with the individual. They're willing to pursue a higher level of care. So you continue to see the individual in outpatient weekly until they have an established placement. And that's often we can kind of create what's called like a bridge plan and sort of usher them into that higher level of care. Also, some of the partially in the bridge plan, you might have to establish, okay, if you start to feel XYZ, you need to present to the emergency department. And so that can be something that the outpatient team needs to consider. Also, an option and probably a really good option is obtaining a release of information, and you call the hospital and ask to speak to the attending team to recommend admission for an inpatient medical bed, because what we often see is there might be some fluids provided and they've had their labs done, but things can change on a dime and things might go back to that, what the original status is. So we might need to really push and consider that higher level of care quicker than maybe what feels comfortable.
Great. Thank you so much, Dr. Neal and Dr. Evans. That was a wonderful presentation. And I just want to hop right into our Q&A because we have a lot of questions. So our first one is from Jenny, and is it a myth or a fact that some inpatient facilities will only admit folks if they meet a certain BMI criteria?
I'll take this one. That is true. Actually, it's not so much the BMI criteria. It's usually a percentage of their estimated goal treatment weight range. So many higher level of care facilities do have to limit that, and often 75 is kind of the magic number. So if a person is less than 75% of their estimated treatment goal weight, they might not be able to accept them. It depends on their level of medical support that they can offer. So I think there's also, it varies. And so I would say if you have somebody who's very low weight, or has lost a significant amount of weight very quickly is the other thing that people want to know about. They have the family or the individual do the intake, and you as the medical provider might need to speak with the accepting medical provider, because I've definitely done that before where I've called and spoken to the attending physician and made the case to say, yes, they're hemodynamically stable. We've gotten them out of the refeeding window. I think that they would be stable enough to come. And so sometimes there are exceptions.
Great, thank you. I'm going to combine kind of two questions here. So one is hearing your guys' thoughts on the role / potential harm reduction processes if a higher level of care is not accessible due to cost and geography, and tying in a question of what happens if you can't offer a bridge plan or like weekly visits, and maybe you're stuck as the lone provider, you're not able to have a team. So kind of just some barriers there.
I think that's the tried and true dilemma that we face over and over again. And so in particular, if you're the sole provider, that's generally going to be your judgment call based on, again, the individual's medical stability, what the course of their illness has been, and if you are able to establish, some measured goals that can keep them safe, but also you do have to consider your practice, your license, and what's going to be essentially the best for everyone involved. And sometimes that does mean making some really hard decisions and drawing the line and saying, I cannot ethically work with you. I'm beyond my scope of practice. Did I answer the other question?
Yeah. Are there any other thoughts that you want to add, Dr. Evans?
No, I think exactly that. And from a geography standpoint too, depending on what comorbidities are going on too, a lot of places aren't able to accept like dual diagnoses or multiple diagnoses. And so sometimes our only option is a different region, not just out of state, but a different coast. And so, from just a safety risk standpoint as their provider, sometimes you do have to draw a line and say, I can't in good conscience continue to care for you in this setting. It's the hardest conversation to have. And again, typically have that when there's a consensus amongst all of the care team members that we have reached that point.
Great, thank you. Another question is from Jenny about being curious on your thoughts about different ED tracks across levels of care. For example, separate IOP or PHP programming for binge eating versus bulimia versus anorexia.
I think every treatment center has kind of different philosophies and approaches that they use. And so when I'm talking with families, I'm usually or individuals encouraging them to look at a few different places. For the kids I take care of, like some of them will use an exchange system for people with BED, or they'll use catering for people with that, or they'll have them in the kitchen. Everybody has a little bit different approach. And again, I'm a pediatrician, so I'm usually thinking about like what are things going to look like when they go back home to their usual setting. And I think that for the youth that I've cared for, especially if they've gone into treatment for a BED, they often find it more helpful to be around other people who are going through a similar experience, and often have found that if they're in a group that's all youth with anorexia, that's not quite the right fit. So I've found it helpful to have different pathways in a way. So would just say from my experience. I don't know, Dr. O'Neill, if you have a different thoughts.
Yeah, this is I've actually, so in my time working at a higher level of care, I've heard the answer that it's best practice to have, you know, a mixed milieu, so to speak, in terms of diagnoses and body presentation. And then I've also heard that it's best practice to make sure to split based on diagnosis and based on essentially like the psychological and social safety of the individual. And so I think what we're seeing is there is certainly a difference of philosophy. And so that's definitely something, if you're considering higher level of care, asking the program about, and in particular, really aligning as best you can with what your client's needs are. And you know, the chances of them succeeding in an environment where they socially feel like they can thrive, like it's the best option available in a really difficult situation, then, you know, it might be one or the other. We don't really know, but making sure to ask your client and just get a good sense, and you probably know too. So, but I don't know in terms of like what the current research is very specifically saying. Be a good study.
Okay. All right. Thank you everyone for those wonderful questions. We kind of have to transition on to our next part.